Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Jyoti Patel from the Northwestern University Robert H. Lurie Comprehensive Cancer Center and Dr. Ani Balmanoukian from the Angeles Clinic and Research Institute, a Cedars-Sinai affiliate. They are excited to talk with us about TIGIT as part of the immune checkpoint pathway and the potential role that anti-TIGIT therapies may play in the treatment of solid tumors. This episode is part of a larger educational program titled Novel Immunotherapy Approaches Targeting TIGIT, Updates and Perspectives for the Oncology Care Team. For more information on the experts, along with a link to the complete program, including a text module with a downloadable slide set and expert commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi everyone, my name is Jyoti Patel. I'm a medical oncologist at Northwestern University Lurie Cancer Center, and I specialize in treating thoracic malignancies. I'm here today with my friend and colleague, Dr. Ani Balmanoukian, and we are going to be talking about novel immunotherapies and TIGIT therapies in treating solid tumors. So certainly, as you know, these past years have really resulted in a revolution of immune therapies for our patients. And we know that targeting of immune checkpoint inhibitors leads to durable and significant responses in subsets of patients. We have multiple agents that target PD-1 and PD-L1 that are now approved for clinical practice across a broad number of tumors. In my disease site in non-small cell lung cancer, I have immune checkpoint inhibitors that are approved in the neoadjuvant setting just recently, as well as in the adjuvant setting after chemoradiation for stage 3 lung cancer. And then we have integration of immune checkpoint inhibitors either on their own or with chemotherapy in the frontline setting for advanced non-small cell lung cancer without driver mutations. Despite these therapies, unfortunately, the vast majority of patients still either have minimal benefit with single-agent immune therapy or eventually progress despite chemotherapy and immunotherapy, and now also CTLA-4 and PD-1 inhibition. And so there's a huge unmet need for other novel therapies. Certainly, we have seen that immune checkpoints and immunotherapy pathways can be redundant. Tumors can evade immune surveillance by a number of host and tumor mechanisms. And so to shed, I think, a little bit more light on this, I'm going to ask my colleague, Dr. Balmanoukian, to talk a little bit about different compounds that may improve our outcomes with immunotherapy.
Thank you so much, Jyoti. And it's a pleasure to be here. It's a pleasure to be here with you to discuss this very interesting topic. And thank you so much for that wonderful introduction. Just as a way of introducing myself to everyone, I'm Ani Balmanoukian. I'm part of the Angeles Clinic and Research Institute in Los Angeles, which is a Cedars-Sinai affiliate. I'm the director of thoracic oncology, so my focus is thoracic oncology, and also the associate director of the phase 1 immuno-oncology program here. And as Jyoti was mentioning, there's a lot of excitement with the novel immunotherapy agents coming onto the scene over the last few years, especially with the new checkpoint inhibitors that we have been using. Checkpoint inhibition changed the landscape of how we're treating multiple malignancies, and especially non-small cell lung cancer. And so we're trying to build on our knowledge where these immune checkpoint inhibitors fit into our treatment paradigm, and also the new agents where we can continue to improve patient outcome. So TIGIT is upregulated by immune cells, including activated T cells, natural killer cells, as well as regulatory T cells. And what it does is it binds to two ligands, the CD155 as well as the CD112, which are both expressed by tumor cells as well as antigen-presenting cells in the tumor microenvironment. And so it's basically a means for the tumor cells to evade immune recognition. And as you mentioned previously, there are multiple mechanisms that tumor cells are using to evade the immune recognition, and this just happens to be one of them. So they have used single TIGIT antibodies in the treatment of various malignancies. The data there has been limiting. But more recently, they have used the TIGIT compound antibodies using combination therapies, including with other checkpoint inhibitors. And we know that one such trial was the Cityscape trial, the phase 2 Cityscape trial that was presented at ASCO, in ASCO 2020, so almost 2 years ago. And Jyoti, I would be very interested to hear your thoughts on that trial and what you thought about the overall response rate and the progression-free survival, as well as the patient selection of that study.
That's great. We've been hearing about Cityscape for a couple of years, and we had the initial presentation, as you said, at ASCO 2020, and then a more recent update at ESMO, and it certainly led to a lot of excitement. So this was a phase 2 randomized study, double-blind, in which patients with at least some PD-L1 expression, so tumor proportion score of 1 or greater, and who were EGFR and ALK wild type, were randomized to either atezolizumab alone with placebo or atezolizumab plus tiragolumab. Both of these drugs were given Q3 weeks, and the primary endpoint was overall response rate as well as progression-free survival. So in the intent to treat population, so this was like 135 patients, in the intent to treat population, the response rate was higher with dual therapy with tira and atezolizumab, 37%, versus atezolizumab alone, about 21%. Interestingly, in sort of pre-planned subset analysis based on PD-L1 expression, in those patients with high expression, so PD-L1 tumor proportion score greater than 50%, those patients that probably, I know you and I would treat in practice with pembrolizumab alone. So those patients, the response rate of the combination tiragolumab and atezolizumab was 66%. It was 24% in the atezo alone arm. And so certainly a significant increase with the dual therapy in this population, and it was 58 patients. In the patients who had a tumor proportion score between 1 and 49, who often we'll treat with a combination of pembrolizumab and chemotherapy, in patients who may not want chemotherapy or who may have other reasons, often we treat those patients with nivolumab and ipilimumab. But in this population, the response rate for atezolizumab was only 18%, and the combination was 16%. So really no difference. So most of the effect was being driven in those patients with high PD-L1 expression. So certainly, I think this is thought-provoking. Does this sort of evade sort of immune escape? Is this another checkpoint that we can use? Certainly in this phase 2 trial it is. But I just caution to say that I think the atezolizumab alone in these high patients was a little bit lower than I would have expected. So we know pembrolizumab in PD-L greater than 50% has a response rate that's just shy of 50%. So again, a little bit lower than I would have expected. Progression-free survival was the other co-primary endpoint, and that correlated with the response in which there was a significant separation of the curves in those patients who are high expressors. And I think the quadrupling of median PFS, so 4.1 months to 16.6 months with the combination arm. In those patients who were the 1 to 49 expressors, there's really no difference, 3.6 months and 4.0 months. We saw updated OS data more recently at ESMO this year, and that carries out really no unexpected signals. The tira and atezo arm, in again, the high expressors really had a nice improvement, so much so that the hazard ratio was 0.23, so a real significant benefit. Other data that was presented in the context of this trial, and that we're always interested with when we give dual checkpoint inhibitors, is there increased toxicity with one drug over two? We've certainly seen that with CTLA-4 inhibition, in which there's greater rates of drug discontinuation and higher IRAEs. In this, again, 135 patient participant trial, there was a trend towards increased toxicity, but in my opinion, not so significant in terms of serious AEs, about 50% versus 40% in monotherapy. Immune-mediated AEs, grade 3-4, 19% versus 6.2%. So, I think these are, so far, a pretty well-tolerated therapy.
I agree. I think that an adverse events profile looked very easy to tolerate and essentially on par with what we've seen with other immunotherapy trials. There wasn't anything that was necessarily stood out for me, and the results looked promising. I also wanted to get your opinion on what you thought about the selection for the marker, using PD-L1 as a marker of response. Unfortunately, basically one of the best options we have in terms of marker to gauge a response to immunotherapy. But I just wanted to get your opinion as to what you thought in using that in this study with this combination.
So certainly all of us have some discomfort with PD-L1 because we're so binary, right? We like mutations. Either you have it or you don't. And we have often with great certitude, the likelihood that you'll respond is quite high. And if you don't have it, it's not there. PD-L1 is tough. Even in patients with high responses, we've seen, both you and I have treated patients in clinic who don't respond, unfortunately. And when we look at all the data, it's about 50%. And so it's really hard, I think, to make a patient selection for a drug that may not target, PD-1 based on a marker that we've had problems with in terms of prognostication and predictive value. It's not nearly as high as we'd like it. Certainly in this trial, in that sort of high PD-L1 population, is a phase 2 trial really selected for enhanced outcome. And certainly, the industry has followed that. There's a phase 3 trial ongoing that is specifically looking at PD-L1 greater than 50%, Skyscraper 01, that is looking at Tira plus atezo as frontline therapy. So certainly that's a signal that we've got, but with all of the caveats of why was this population underperforming with atezo alone, it's a little bit tough for me to reconcile. So I think it may help, but certainly I don't think drills down on host environment and tumor microenvironment to the degree that we'd like it to if we could really predict and predict best response to truly personalized therapies. What do you think about emerging markers?
Yeah, I think they're definitely necessary and much needed, especially in clinical practice. I think the tumor mutation burden being utilized as a marker, there was a lot of excitement for that a number of years ago. Unfortunately, it didn't pan out very well. But I have to say, I still look at the tumor mutation burden when I get the next generation sequencing on newly diagnosed patients. And so to me, I still utilize that as a marker. In regards to other emerging markers, nothing has stood out for me yet in terms of a marker that I can use. I think we're all looking to see what the next best marker will be. And I know that a lot of these trials are looking to see if selecting for specific markers, at least in terms of the pathways that they're targeting, is going to pan out. But nothing that has stood out for me, at least in terms of actual practice. How about you?
I would agree that I end up paying attention to tumor mutation burden, even though I don't think it directly influences my choices. It's not that if this is high, I'm definitely going to do one thing. It absolutely gives me greater comfort when I'm deciding to do immunotherapy alone approach. Now all of us are getting next generation sequencing. And so we're also seeing mutations in STK, for example, and I think making some assumptions about responsiveness to chemotherapy, but it's really going to take prospectively designed studies to really tease out the multitude of influences, I think, for many of these therapies. But certainly, TIGIT is exciting. There are phase 2 and 3 trials with other compounds that are somewhat similar. Vibostolimab is one such drug that's shown efficacy in lung cancer, melanoma, GI cancer, certainly. But, I think it's going to be really deciding whether this is just another drug that we add in a broad patient population or whether we really start selecting. Skyscraper 2 is atezo plus tiragolumab in small cell cancer. And so even, I think certainly immunotherapy is an important part of treatment for small cell lung cancer, but I think we all recognize that the benefits of immunotherapy are really confined to a small number of patients. We just don't know how to pick those patients yet. And I worry that's going to be the same with these combination of drugs.
I completely agree. Another trial I found interesting was the Skyscraper 03 trial, using it in the adjuvant setting after tiragolumab plus atezo versus durvalumab in stage 3 non-small cell lung cancer. So I thought that was an interesting design, and I'd be very curious to see what the results pan out to be. One other place that they're using this combination in the clinical trial is also in the neoadjuvant setting in the Skyscraper 05 trial. And so, of course, there's a lot of excitement now in using immunotherapy in the neoadjuvant setting. Of course, we just recently got an approval along with chemotherapy in the neoadjuvant setting for nivolumab. And then, of course, we're also using immunotherapy in the adjuvant setting. So I thought this trial was also interesting in terms of trying to use the combination in the neoadjuvant setting and, essentially looking at both populations with PD-L1 greater than 50%, and then the group with PD-L1 that are all comers. And again, combining tiragolumab with atezolizumab. And so that's also an interesting design, and we'll see how that pans out as well. So it's exciting to see that TIGIT is being utilized in many different ways. And so adjuvant in the stage 3 setting, post-chemotherapy, radiation, and of course in the metastatic setting. But the landscape is still open to interpretation, and I guess we'll see where the data takes us.
Yeah, that's a great point. So we have almost an abundant number of drugs that we can use right now in patients with advanced disease. And again, we have a long way to go. We need to increase these benefits to everyone. But if you were meeting a patient perhaps with high PD-L1, prior smoker, sort of low TMB at this juncture, and the phase 3 results sort of are positive. I don't know how positive, but imagine that Skyscraper 01 is positive. How do you decide between pembro and then combination therapy?
I think eventually it's going to come down to the overall response rate and the adverse event profile. I would also throw in ipi-nivo in that mix as well, since I do use ipi-nivo combination as well. And so how do you tease out pembro versus ipi-nivo versus TIGIT and atezo? I think at the end it's going to come out to, let's see what the overall response rate ends up being, and if it actually, at least in the trial itself, of course it's not a head-to-head comparison, but if we gauge to see significant overall response rates. I think on the one hand, it's good to have options. On the other hand, it's going to be challenging to know exactly what's the best treatment option for each individual patient when we don't have really any marker other than the PD-L1 to drive us. How about for you in the same setting? How would you gauge that patient and the treatment selection?
I think it's going to be driven, as you say, by response and toxicity. Certainly the Q6-week dosing of pembrolizumab is super convenient for some patients who, after they are comfortable with their diagnosis and initial therapy, spending less time with us is certainly exciting. I anticipate that tiragolumab is an antibody, so I'm sure that they're looking at dosing schedules on top of atezolizumab. So I think a lot of joint decision making. It's unlikely that we're going to see head-to-head comparisons of any of these drugs.
Yeah, I agree. On a personal level, using the TIGIT molecule, you and I have had both experience using TIGIT, different molecules of TIGIT. We have a patient in our clinic with stage 4 melanoma who's a lovely 58-year-old gentleman who's previously has been treated with nivolumab when he had disease recurrence, and then subsequently with nivolumab and ipilimumab with mixed response. And we subsequently got him on a combination anti-PD-1 and TIGIT combination therapy on a clinical trial, and he continues to be on the study with a very nice response. So he has had a very nice response with very minimal adverse events documented so far. So we're seeing these agents work in our patient population. This is a patient with melanoma where we're seeing a response. The data available so far is with non-small cell lung cancer. And as we were mentioning, these agents are being used in various disease types. And so we'll see where we end up using these agents in the future. But certainly the data in the non-small cell lung cancer seems promising.
I think another emerging issue that we have that sort of reminds me of the melanoma patient is, now we're seeing patients who recur soon after adjuvant therapy or after chemoradiation on durvalumab. And so that's a totally different patient population than de novo metastatic disease. And so it may be that anti-TIGIT therapies might be especially helpful there. It may be that, there again are immune signatures that we can really leverage to allocate best therapies.
That's a great point. I completely agree.
So clearly there are huge unmet needs in lung cancer, but we're making our way, with all of these new agents and understanding sequencing. Certainly predictive biomarkers are going to play a significant role. In the meantime, we await these clinical trials on anti-TIGIT therapies, and we will follow enrollment on these phase 3s very closely, because I think there's a lot of interest in our community about bringing these drugs to our patients. Annie, any last words?
I completely agree. I don't think you could have said it any better than that. It's an exciting time to be in oncology, especially being a thoracic oncologist. We await the results of all these interesting studies, and we'll wait to see what role these new therapies have and the options we have for our patients. And it's been a pleasure to be here with you, Jyoti, and it's been a great discussion.
Thanks so much. I appreciate it.
Thank you very much, Dr. Patel and Dr. Balmanoukian, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Novel Immunotherapy Approaches Targeting TIGIT, Updates and Perspectives for the Oncology Care Team, and to access additional resources associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.